Dear doctors, dear colleagues, today we are very pleased to welcome you to this international live webinar about nocturnal hypertension. Nocturnal hypertension, it's a new concept which emerged about 10 years ago with the practice of ABPM. It has been developed and assessed during the last decade, and it's now considered as a serious challenge that need to be tackled. But how? What are the new approaches in the diagnosis of nocturnal hypertension and its management? In order to address this issue, several experts are with us today to discuss a number of points regarding this nocturnal hypertension. Before introducing the other experts, allow me to introduce myself. I am Professor Roland Asmar from Paris. I am cardiologist, hypertension specialist. I am the past chairman of the working group of blood pressure monitoring of the European Society of Hypertension. We have the chance to have with us today number of experts in this issue, and also some practitioners and nurses to highlight the practical points on this. First, we are pleased to welcome Professor Terry McCormack. Terry is the president of the British and Irish Hypertension Society. Please, Terry, can you introduce yourself? What's your interest in this topic and about nocturnal hypertension? Please, Terry.
Okay, so thank you for that, Roland. I'm Terry McCormack. I'm Professor of Primary Care Cardiovascular Medicine at Hull York Medical School. And my background, my interest is that I am a GP, and I'm a GP in Whitby in North Yorkshire. My interest in nocturnal hypertension is very recent, and I'll explain why that is as we proceed.
Thank you. Thank you very much, Terry. Let me add that you are also involved in the guidelines and the NICE guidelines, and you know very well the topic. We have the chance also to have with us today Melanie Dunwell. Hello, Melanie. You are a senior practice nurse at Whitby. Can you tell a bit more about yourself?
Yes, so I'm a practice nurse manager. I've been a nurse for 25 years, but for 20 of those, I have worked in general practice alongside Dr. McCormack. And obviously, we concentrate a lot of our work on the chronic disease management, which includes hypertension and diagnosis of hypertension. And so it's a quite big part of the nurses' work and the HCA's work as well.
Thank you, Melanie. So we count on you to see the practical issue of this topic. Thank you. And with us, also we have the chance today to have Dr. Mathew Capehorn. Please, Mathew, can you introduce yourself and why you are interested by this nocturnal hypertension?
Thank you. Well, I'm still very much a full-time GP in South Yorkshire in the UK, but for the best part of 20 years, I've been a GP with a specialist interest in obesity and diabetes, and I'm clinical manager at the Rotherham Institute for Obesity, where we've seen lots of patients with comorbidities such as obesity and sleep apnea, which I hope I get the opportunity today to explain the link between this and conditions like nocturnal hypertension.
Thank you very much, Matt. This is important because, as you will see it, these two topics, sleep apnea and obesity, are something very important with nocturnal hypertension. So today, together, we are going to address several issues related to the nocturnal hypertension, and afterwards, our audience will be able to ask a question on the subject. And all viewers can ask your question in the Q&A box below the video player. So please do not hesitate to ask your question. Let's start with the beginning. Let's start with the physiology of nighttime blood pressure. For patients suffering from hypertension, is their blood pressure the same during the day as during the night? Question. And before answering this question, let's start with the basic. And the basic is, let's see it with Terry. Terry, can you tell us why you are interested by nocturnal hypertension?
Okay, so thank you for that. So why am I interested in nocturnal hypertension? Well, to be absolutely honest, I wasn't particularly interested in nocturnal hypertension until very recently. And I'll explain why that is. But first of all, I'm just going to show you, no, I was going to show you my declarations of interest, but here we are. So these are my declarations of interest. And as Roland said, I'm president of the British and Irish Hypertension Society, and I'm the first ever GP to be president of this society. And I was also involved in NICE guidelines from 2009 to 2019. The guideline that was published in 2011 was the one that actually introduced the importance of out-of-office blood pressure measurement and recommended ambulatory blood pressure monitoring. So I only very recently became interested in nocturnal hypertension for the very simple reason that I couldn't measure it until recently. Now, it's over many years, we've improved our techniques in measuring blood pressure from much better than 1733, when in essence they are measuring blood pressure in a horse, and it literally is blood pressure. They're measuring it in blood, 8 feet 3 inches of blood, and the horse is asleep, thank goodness. Now things have got a lot better over the years, and we've got many different devices now. And the reason that I'm becoming interested in nocturnal hypertension is because of a device that we're going to talk about today that makes it possible in primary care. Now, there is a difference between what we do in primary care and what specialists will do in specialist clinics. And ambulatory blood pressure monitoring is very popular in specialist clinics, and therefore we are aware of dippers and non-dippers. So non-dippers are the difference basically being the percentage change in blood pressure. Which is subtly different to nocturnal hypertension. So nocturnal hypertension is possibly defined as a nighttime blood pressure greater than 120 millimeters of mercury systolic and 70 diastolic, whereas dippers and non-dippers are recognized from a 24-hour trace. Now, the simple truth of the matter is we don't do much of that in primary care. We have the capacity, and we're going to talk about that as we go along, to do it, but we don't particularly practice it. We're much more keen on home blood pressure monitoring. And so are our patients. And there's good evidence that patients prefer home blood pressure monitoring to ambulatory blood pressure monitoring. So the vast majority of our measurements in Whitby over many years now have been with home blood pressure monitoring. But of course, we cannot measure blood pressure, or we cannot measure nocturnal blood pressure, because to do that, the patient has to wake up, has to put the device on, and that's not practical. So therefore, we're not really aware of dippers and non-dippers, and we're not really aware of nocturnal hypertension. And we're, quite frankly, I think in most primary care centres, most people wouldn't see any particular reason to have that interest. The problem with ambulatory blood pressure monitoring, and I'm sure that Melanie will talk about this as well, is that it basically doesn't give you a true night's sleep. It's measuring a false measurement in a sense, because it disturbs your sleep. On the NICE guidelines in 2011 and 2019, we did not recommend that you carry out nighttime measurements. So with ambulatory blood pressure monitoring, we were suggesting that you do it in the daytime only. And there's two reasons for that. One is that it does, there's three reasons. One is it does disturb sleep. The other is that the evidence was that daytime measurements are as effective as nighttime measurements in diagnosing hypertension, nothing to do with nocturnal hypertension, but hypertension per se. And the other was a practical reason that you can actually do more measurements if you stick to daytime. There's a better turnover of the ambulatory blood pressure machines. We recommended ambulatory blood pressure monitoring ahead of home blood pressure monitoring, simply because that's where most of the evidence is. It's very difficult to do randomized controlled trials on home blood pressure monitoring. In fact, it's impossible, whereas you can do it with ambulatory blood pressure monitoring. I think most people are aware of this morning surge in blood pressure, and then a reduction in blood pressure during the day, and then the dipping at night. But I'm sure that most people are also aware that there's a higher incidence of events in the morning, of cardiovascular events. And we know from various studies that nighttime blood pressure is a better predictor of fatal and non-fatal CV events. But we don't do it in primary care because until now, we couldn't really effectively measure it.
Okay. Okay, thank you very much, Terry. This was very important because you highlighted two important issues for me. The first one, which is we were not aware about nocturnal hypertension, and that's why we are interested since not so long, and now we are more and more interested because we are measuring it, and we have the possibility to do it. If I understood, please correct me, Terry. You have done the differences between deepers and non-deepers and high nocturnal blood pressure. They are two different things.
Yeah, they are different. Nocturnal hypertension, as I said, per se is where your blood pressure is greater than 120/70 at night, whereas dippers and non-dippers are it's a percentage difference in the mean blood pressure of between 10 and 20%. And so if you're a non-dipper, if there is a less than 10% change, and you're an extreme dipper, if it's more than 20%, which in itself may also be a problem. But also there's a lot of unknowns here. There's a lot for us to discover about this because, as Roland, you said at the beginning, this is a new concept. It's only really been a concept that people have taken a particular interest in over the last 10 years or so. And in primary care, it's an issue that's starting now.
Thank you, Terry. And we note also that you mentioned that nocturnal hypertension, it's an important and independent predictor of cardiovascular events. We will certainly discuss about this at the end. Let's move to the other aspect of nocturnal hypertension. We are interested because it's a predictor. We are interested because we can measure it. How we can diagnose this? How we can diagnose this? Please, Melanie, with your experience, can you tell us your experience about how we can diagnose this and explain a little bit the differences between ABPM and the new devices? Please, Melanie.
Yeah, right. So in primary care, obviously we do an awful lot of blood pressures, and what we tend to find is the clinic blood pressures are more than often raised, a lot of white coat hypertension. And so we send patients home with either a 4-day, if they're existing hypertension patients, or a 7-day alone of a usual brachial arm blood pressure monitor, or the 24-hour blood pressure monitors. What we find is that patients do prefer doing them at home, like Terry said. But we do get a fair amount of problems arising from actually sending the patients home with these devices. And the 24-hour blood pressure machine that we've been using for the past few years has not been without its issues. Patients generally don't like it because it's going off every 30 minutes. We initially started sending them for 24 hours and them sleeping with it, but they really didn't like that because there was a lot of sleep disturbance, and it's an uncomfortable thing to have happening every 30 minutes, although we did drop it down to an hour. We did find that patients often took the monitor off and then didn't put it on properly, even though it actually has an diagram on the cuff. But they really didn't like the fact that it's squeezing their arm every 30 minutes. They couldn't drive with it on, and if they drove for a living, this too was an issue. And also when they found it quite bulky, if it's obviously in the winter when they've got lots of layers on, having a blood pressure cuff going off every 30 minutes is not very practical. Introducing the night view monitor has made a difference because they much prefer the slimline sort of design, because it's on the wrist as well, so it's not actually interfering with the clothing and it's not as uncomfortable. I think generally speaking, they seem to be preferring this. There's still some issues with patient compliance, and obviously patients taking readings or giving their device to somebody else to do readings for them as well, which can obviously interfere with the data as well if you've got somebody else's readings on there and you're not aware. 24-hour blood pressure monitor, from a nurse's point of view, it's quite, it has problematic software, so when we're trying to program it, it can take a considerable length of time to get it to work. And the one we use at the moment took me 35 minutes to actually program this morning before it was actually given to the patient. And the patient arrived in some very inappropriate clothing, and it made it more problematic to actually get the appointment completed in the time allowed. So that's not ideal. So I think what we find is, because of the night view being just on the wrist, it's easy to fit. It doesn't have the temperamental software. It's quite straightforward for the patients to apply themselves if they've taken it off. They can do the home readings through the day without too much issue. There's an easy explanation as to how to apply it to the wrist. It's literally, you're going to press it, it's taking your blood pressure, it's very minimal amount of pressure, so the patients quite like that. And also in the night, all they have to do is to press the night mode, and it will take 3 readings, 2 a.m, 4 a.m, and 4 hours after they've pressed night mode. And most of the questionnaires that have come back have said that it didn't actually disturb their sleep at all. They haven't woken up with it, and if they did, it was just very briefly and not, they didn't find it intrusive to the sleep at all. So that in itself speaks volumes. So you are going to be able to get those nocturnal readings that we aren't getting at the moment with the 24-hour ABPM. The results from the night view monitors are much easier to download as well. The ABPMs, you need to download it and then convert it to an Excel file, and it's not as user-friendly as it could be. Whereas the night view monitors, we are literally downloading it on a Bluetooth connection, and then the readings are there. So it's been, on the whole, a much better device and wholly welcomed by the staff and the patients.
Thank you very much, Melanie, for this very important aspect, the feedback from the practice. I will say. So if we understood 24-hour ABPM have number of limitation, and we maybe can discuss this later on during the discussion session. And among these limitations, there is the sleep disturbance, the time consuming for the programming and reading the data and so on. But the feedback in your daily practice, the feedback, as you mentioned it, with the night view, it's a kind of a new opportunity for this aspect for nocturnal hypertension. Do you agree with
that? Definitely. Definitely, yes. I think the ease of use, it's easier to put on, but also I think the no waking thing is the major improvement, because with the ABPM it was just impossible for somebody to get some sleep. Even if we set it to go off on an hourly program, it was still very intrusive, and that's going to upset the patients. They're getting a poor night's sleep. You're not going to get the right readings. With the night view, if they don't even know it's going off, you're getting the more realistic readings throughout their sleep, and in the morning they're just going to take it off and use it through the day as you would a brachial one, but on the wrist instead. So quite straightforward for them to use, and we've had a really good feedback from it.
That's good. That's good. And a pragmatic issue, did you face any problem with the night view in terms of number of measurements during the night? In some patient, it's working in all patients, it's working good. Do you have any comments on according to your experience, or the device is programmed to measure maybe 2, 3, 4 times during the night, a number of measurements available and accurate. Can you comment on this?
Yeah, we've had, I think the only person that we didn't get a reading of on the batteries, she'd taken the batteries out and put them back in again for some reason, so it didn't record. But everybody else, we've had readings at the 2 a.m., 4 a.m. and the 4 hours after. I think the only time we've had any issues at night where somebody had hit their wife with their machine by accident, but that was just a positional problem rather than anything else. And it does actually work really well, even though patients have a different sleep position. The daytime readings, you need to position your arm correctly, and there's a light on the machine that shows you, but when you're actually in a sleep position, it records it anyway, so you don't have to hold a position anywhere particular. So the patients like that.
So it's easy to do. Thank you for your feedback. So we understood why it's important to be interested by nocturnal hypertension. We also had your feedback, Melanie, that we have different techniques to measure it, ABPM and the night view now device, which seems to be more acceptable and so on. Allow me, Terry, to come back to you. In what type of patient shall we look to this nocturnal hypertension? Shall we look for it in all our patients, or do you have a kind of type of patient? What do you think about it? And what type of patient we have to look on these nocturnal hypertension?
So at the moment, we're actually using it in all our patients, except for obviously people who have atrial fibrillation, and because it's an oscillometric measurement, so it's not accurate in irregular heart rhythms. And also, if somebody has a very large or a very small wrist, it doesn't work. And certainly a development that we need to see are different sized monitors, which I'm sure will happen eventually. But there are certain people who are more likely to have nocturnal hypertension, and they're people with obstructive sleep apnea, and we're going to hear from Mathew about that in a minute, people with obesity, but basically the people with metabolic syndrome. We don't know, and that's why there's a chicken and an egg here. We don't know precisely what's happening. We think that there's a sympathetic overdrive, but what we don't know is whether it's the hypertension that's driving the sympathetic overdrive, or the sympathetic overdrive that's driving the nocturnal hypertension. So there's a lot to learn. And I think that because we now have a new way of measuring this, I think we're at the start of a journey to find out more and more about this subject. One of the questions would be, you know, what can we do about it if we've diagnosed a problem like this? Now, one of the things we can do is use longer acting drugs with longer half-life. I think it's very important that we use combinations of drugs. And I think one of the problems we've got in general in treating hypertension is that we possibly don't use enough drugs. We're better using lower doses of 2, 3, 4 drugs than necessarily maximizing doses. We can obviously tackle the problems that are there. So with sleep apnea, we can treat the sleep apnea. With obesity, the clear and obvious thing, and Matt's going to talk about this, is to get people to lose weight. But one of the other suggestions is that that people take their medication at night. Now, I'm not absolutely convinced by that. I don't think we know whether that works or not, truly. My problem with advising people to take their drugs at night is that it goes against my lifelong mantra, which is take your drugs when you can remember to take them. So for some people, taking it in the morning is the best time because they're more likely to take them. And obviously adherence with medication is very important, and it's a big problem in hypertension. Now, we had the Hygia chronotherapy trial recently, which suggested that people did better if they took their medication at night, and that may well be true. There were some problems with that trial in that the two groups of patients weren't as well matched as you'd like. There were more people who'd had previous events in the morning treatment group, and the morning treatment group had more people taking beta blockers and thiazide diuretics, and that could have created a change, because we saw that in the Ascot trial where beta blockers and thiazide diuretics didn't necessarily quite work as well as calcium channel blockers and ACE inhibitors. But as again, we're going to find out more from the TIME study, which colleagues in Dundee, the University of Dundee, have organised. That's likely to give us some results later this year, and that will either confirm or deny the results of the Hygia trial. So yeah, we've got the night view that we're now using on several patients in Whitby. It has 2 modes, as Melanie's suggested. It's a very neat device in that it sits just below your wrist. So it basically sits where your watch and more proximal than that. And it's very comfortable to wear. And because it's got dual cuff, it doesn't exert as much pressure. It's very quiet when it goes off at night. You have to set it to a nighttime mode, and as Melanie said, it will take 3 readings. And in most cases, the patients are telling us that it doesn't disturb their sleep. It's a little bit more difficult to use in the daytime because it's positional. So you have to get the light has to be indicate that you're in the right position to do that. So in truth, what we are mainly using it for its nocturnal use. We are still giving patients brachial cuff home blood pressure monitoring machines, as well as the night view, so that we can, because we're confident in the use of those. The machine is validated. It's validated with laboratory testing. It needs more validation, in a sense, in that we need real world validation or real time validation. And we're not actually doing a validation study in Whitby, but we are looking at that aspect of that. And as I've said before, we're on the start of a journey here. The thing about the night view is it's the first machine of its kind, in a sense. There are other similar machines, but it's the first time that we've had one quite like this. And so in essence, it's become it will be the gold standard for this type of check. And again, as I've already said, it's creating the possibility of having an interesting nocturnal hypertension in primary care, where we are dealing with large numbers of patients. We have 2,500 people in our practice who are treated hypertensives. So that's an awful lot of people to monitor, but we also have a huge population who we need to carry out diagnostic treatments in as well. And so, yeah, we're going to take it forward with this and see what happens.
Thank you very much, Terry. These are important points which has been highlighted. I understood that the device is using the oscillometric technique, and there is a limitation for the oscillometric technique by itself. And you mentioned the arrhythmia, atrial fibrillation, and so on. But also, I note that the device has been validated according to the, let's say, validation protocol, well-known validation protocol, AMMI, ESO, and ESH protocol, which is very good. That means the device is accurate. Allow me to go back to one issue about the suggestion of chronotherapy. In patient who is presenting nocturnal hypertension, shall we give him the pill in the morning or in the evening, or as you said, yeah, when he remember, we will discuss maybe a little bit more this chronotherapy issue later on. But what do you think if people are under combination therapy? Shall we give him all the treatment in the morning, or can we dispatch the treatment between morning and evening according to the nocturnal blood pressure? What's your experience about this?
My experience is that that the best way to get good adherence is to ideally use once daily drugs and take all your medication together. So the BD TDS regimes are less likely to follow. You're more likely to miss your pills with that. So that's my concern there. And as I said, I say to people the most important thing is that you take your pills, and so take them when you can remember to take them.
Thank you.
I try to avoid splitting therapies.
Okay, thank you. We will come back to this because you mentioned a number of important points in your presentation, and mainly about the patient profile and the metabolic syndrome. Let's stay in this issue, and let's go to Mathew. Mathew, please, can you tell us which patients are at risk?
Certainly, it'd be a pleasure to. Obviously, we've already said that some of the biggest risk factors for nocturnal hypertension are patients with sleep apnea and obesity, and these have a chicken and the egg relationship. And I'm going to explore this further. These are my declarations, and over the last 20 years, I've worked with all of the companies involved in obesity and diabetes to maintain my integrity in terms of prescribing. But in order to understand sleep apnea and obesity fully, we need to take a step back and look at sleep and the relationship with weight gain, first of all. And it's really important that we all get the right amount of sleep. As soon as we become sleep deprived, as little as a few hours less than we actually need has a result in increased weight. And we know that from a combination of the body makes changes that increases calorie intake and reduces energy expenditure. On this slide, this is the easiest way I could think of explaining it. As well as being awake more when you're sleep deprived and therefore more opportunity to eat, there are changes at a metabolic level with a gut hunger hormone, ghrelin, and leptin, which works in the opposite way in a seesaw relationship. Now, these are just two of several different gut hormones and neurotransmitters that we now know are associated with appetite and increased desire to eat. Now, these changes result in increased calories, increased weight. But as well as that, there's reduced energy expenditure because sleep deprivation alters our thermoregulation, increases fatigue, so we're exercising less, but then also as a consequence of increased hormones, stress hormones like the catecholamines and cortisol, you end up with a state of less concentration, less alertness while you are awake. And so together, all of this results in weight gain. Now, we've actually subsequently found out from studies that there's a massive difference in just a few hours of sleep deprivation. And as we can see, those two hormones we've already mentioned, ghrelin and leptin, can change by as much as 15%. And the consequence of that on the body is that over time, it can make 3.6% difference to your body mass index. So there's overwhelming data now that suggests that sleep or lack of sleep increases the likelihood of obesity. Now, we don't want to become obese and put weight on. We know that increased weight around the neck and those people with a wide neck and perhaps those people with less toned muscles around their neck are more likely to suffer with this condition called obstructive sleep apnea syndrome, where the upper airways repeatedly collapse during sleep, obstructing the airway, and it causes you to stop breathing. That's what we call an apnea, where you literally stop breathing for 10 seconds or more, or a hypopnea, where it's not enough breathing. And we measure this together as an apnea hypopnea index, or AHI. And we now have ways of measuring this in individuals to see how prevalent a condition it is. Now, those people that are more likely to have sleep apnea, we've already mentioned it. If you have a look, 83% of those patients with drug-resistant hypertension are more likely to have sleep apnea, 77% with obesity, 76% with congestive heart failure, but also AF, diabetes, coronary heart disease. So there's definitely this association with the metabolic syndrome and cardiometabolic renal disease processes. And there's a pathological theory as to what actually is going on. When we're awake, our airways stay patent and it compensates. But then when we're asleep, you have that decreased compensation, which results in your airway collapsing if you're overweight or don't have those tone muscles, and can lead to either snoring or that sleep apnea. What actually happens to the body is there's a period of hypoxia or hypercapnia, and increased effort to keep breathing, possibly as a result of sympathetic adaptation. It wakes you up and your sleep is fragmented, but then you hyperventilate and the vicious cycle continues again and again. So there is theories as to why this is actually happening. But when we go back to how common it is, you might think, well, I don't really see much of it in primary care. Well, the problem is 80% of patients with significant sleep apnea go undiagnosed. With an AHI above 5, which is by definition a degree of sleep apnea, 24% of men, a quarter of men, and 9% of women between the ages of 30 and 60 with a BMI in the overweight range, so we're not necessarily talking clinically obese, have technically sleep apnea. And if we go for the higher threshold of an AHI of 15, 9% of men, or a tenth of men, and 4% of women between 30 and 60 in the overweight range actually have this higher threshold of sleep apnea that might benefit from one of the forms of treatment for sleep apnea. Now, this is so prevalent, it's very worrying that a potentially fatal condition like this goes so underdiagnosed by GPs. So what can happen if we don't treat this patient? Well, the expected ones are perhaps they might be snorers, they might have disturbed sleep, they might be waking themselves up with choking episodes. These are the patients that say, they wake up in the morning, they think they've had a decent 8-hour sleep, but they're not refreshed. They're always tired. They very often have a morning headache and they're tired and sleepy all the way through the day. They very commonly fall asleep, especially after a drink of alcohol or in a quiet moment in the afternoon. They're always tired and they're much more likely to have car accidents. Now, sleep apnea is an independent risk factor for all of those other cardiometabolic renal diseases that we've already mentioned, like hypertension, cardiovascular disease, CVAs, glucose metabolism, and diabetes. So, what can we generalize about the patients who are at risk? Well, they're much more likely to be obese, much more likely to be male. It does increase with age. There is a family history associated with sleep apnea. All of those patients with anatomical abnormalities of the upper airway, in particular those with a wide neck, the typical Mike Tyson phenotype, those who drink a lot of alcohol or use sedatives, and those who smoke are at risk. So how do we actually think about screening for these patients? Well, any patient that comes into primary care or even secondary care complaining of tiredness and being unrefreshed by their amount of sleep. Any patient with newly identified hypertension or resistant or refractory hypertension, all those with heart failure, nocturnal angina or cardiovascular disease, all of our patients with severe or complex obesity, our bariatric patients, should be considered and screened. But patients with those large necks, so what we mean by large, 17 inches for a man, 16 inches for a woman, and because of the anatomical abnormalities, those with small jaws as well. Now, as we've already said, there are things that can be done for patients with sleep apnea. And one of the big focuses, from my perspective, is to treat and manage the obesity. Now, we have behavior modification down there, and we have surgical treatments down there, as well as treatments like CPAP for the sleep apnea. But what I would say now is watch this space, because really we need at least 10% or 10 kilos weight loss to really make a difference to sleep apnea. And now we've reached that stage where we don't need to rely on bariatric surgery to get that. Behavior modifications have improved no end, and we can get about 5% weight loss through community weight management programs. We have structured multidisciplinary team approach that can get 10%, but now we're getting weight loss medications that can get us 15% and very low calorie diets that can get 20%. So we might find in the future we don't have to resort to a surgical intervention to do something about a patient's weight and therefore consequently improve their sleep apnea.
Thank you very much, Matt, for this complete, I would say, overview of the topic and the number of important points that you highlighted. Allow me to ask you a question. You show on one of your slides the prevalence of sleep apnea. And according to the definition of the apnea hypopnea index, it's 5 or 15. Can you tell us a little bit more about this? What's the exact definition? It's 15, it's 20, 25. What's the thresholds of AHI? Let's say.
Yes, strictly speaking, you've got a degree of sleep apnea if your AHI is above 5, and that's going to be a huge proportion of the population, but that doesn't necessarily mean it's significant enough to warrant a treatment other than perhaps behavior change. It doesn't mean to say that those patients all need to be going and having CPAP and clogging up our secondary care services. However, many clinicians and many sleep centres go with that other definition of an AHI of 15, where that's the cutoff where they want to investigate further, do more comprehensive overnight oximetry testing to see whether they would benefit from CPAP or a mandibular splint, or a more in-depth, comprehensive, multidisciplinary team approach to their weight loss.
Okay, thank you very much. I am sure that there will be a number of questions about this topic from the audience. Let me ask you one question, maybe to you, Matt. This question is from the participant. it's about in many patients with psychiatric disease, we can see also nocturnal hypertension. Why I'm asking you this question, because he's talking about the psychiatric disease in patient, and in one of your slides, the general risk factors, you mentioned sedative use. Can you comment on this? Anybody, Terry, do you have any experience in patient with psychiatric disease and nocturnal hypertension, or psychiatric treatment, I will say sedative treatment?
Well, in general practice, we have lots of experience of patients with psychiatric illness and its connection. Obviously, people with psychiatric disease are at greater risk from cardiovascular disease. They're often not treated as well as other patients. And of course, one of the problems is we tend to exclude them from trials, and therefore we don't necessarily study them as much.
Okay, Matt, any comments on this psychiatric disease? And
yes, I would certainly add several factors. When I put up the slide about sleep, we've got to remember a lot of these patients have associated mental health problems like stress and depression and anxiety, and so their stress hormones will also be having a factor with their weight. And then the double whammy, we then end up putting them possibly on medications, certain types of antidepressants or even antipsychotics, that through mechanisms that we don't fully understand yet also increase their weight. So these poor patients, as well as perhaps us focusing on their mental health and less on their cardiovascular disease and metabolic problems, we're then treating them with medications and in ways that lead to increased risks of nocturnal hypertension through the obesity and through possible sleep apnea.
Okay, allow me also one more question. This is for you, Matt. It's from the participant. Is the NightView validated and approved by the British Hypertension Society? So as the president of the society, can you tell us if the NightView device is validated and approved by the British Hypertension Society?
It's not been put through our validation processes yet, so no. In short, it's not. The validation evidence comes from Japan, which is where a lot of this work initially will be done, and it's the device itself was invented in Japan and validated there. But yeah, we need more validation evidence for it. As I said, we're on the start of quite a long journey here. This is a unique device, a very exciting, unique device. And yeah, we've got to learn a lot more about it.
Thank you. We maybe if we have time, we can come back to this validation issue, which is important. Let me highlight one point. Since 2019, we used to have at least 4, 5, 6 validation protocol. Our participant mentioned the British Hypertension Society validation protocol. As member of the European Society of Hypertension, we used to have also the ESH protocol. The American used to have one, the AMMI protocol. The German used to have also the German League protocol, the DIN protocol, and so on. So there was number of protocol. And we spent 2 years, and since 2018 or 2019, we have now what we are calling the universal validation protocol, which is a common protocol for the American, the AMMI, the European, and the ESO committee. And I saw in one of your slides, Matt, that the device went through one validation in Japan using this protocol. I agree that we may have maybe a second validation, because is one validation enough? I cannot answer you this. Talking about the device, let me go back to you, Melanie. Can you tell us what are the experiences of patient when using ABPM? What is the difference with the NightView?
So what we've found, obviously I've said before, it's the ease of use really is the main thing, and the lack of interrupting your sleep. But it's not just that, it's about the clinicians as well for me, because obviously we have a large nursing team, and we did have a few teething troubles at the beginning. We didn't really get all the information out to all of the team completely. And so some of the staff found the instructions and the device a little bit foreign, so it didn't quite sit as well with them, so they tended to go towards the brachial arm measurements. So also the instructions that came with the device were extremely small and quite detailed. So we had a few problems with that at the beginning because it was a bit like War and Peace. Some of the staff hadn't really realised about the sighting of the device, and also checking the wrist measurements, check it wasn't too small or too large. We also were setting off with the questionnaires to see what the patient feedback was like, and sometimes these were missed. They weren't given to the patients in error, or there was no traceable ID on the actual questionnaire, so we couldn't trace who it was from. And few people knew what to do with the results when they came back in. So initially it didn't sit quite as well at the beginning. So we decided to have a little bit more of a think about it. So we had a meeting with the nurses and the HCAs, and also with Dr. McCormack, and he came and explained to us the way the monitors work, why they're so much better than the other ones that were at night, and also about the nighttime dippers, which obviously we hadn't come across as much. We also managed to simplify the instructions for both the nurses and the patients. And we developed a protocol for when we actually leave lend the machine out, sorry. So that was much more straightforward. We also give the patients a sheet that they will fill out their results on, and added to that the night view readings as well, because the GPs all find that they have a better understanding of what's going on, and can actually see all the readings on one sheet. Because we can average them or do whatever they want us to do with them, but it's still good to see what's been going on throughout the week or throughout the 4 days that they've had it. And now we can see the nighttime readings when we download them as well. And that's so much easier now. We don't have to plug it in and start to get the programs to work and talk to our system. I think the questionnaires that were given out, we've collated a lot of the information that we've got from those, and it's been wholly positive. It's been really encouraging. And it's the comfort, sleep quality, more consistent results as a result of this, less stress on the patients. And also we understand better the nocturnal dippers. And I did find Matt's presentation interesting because it's seeing it from different perspectives. So really we found that the patient satisfaction has been much higher. And also the nurses, which obviously works well as well. But we have, obviously it's work in progress, like Dr. McCormack said, and we are continuing to send out the machines together, but able to do the nighttime readings, and it's in a much more simpler way. So yes, it's been a welcome addition to our team.
That's good. That's good. Melanie, just for my information, I understood that we need, let's say, information, education of the patient, like any home blood pressure devices, and maybe a little bit more. Do you have any video tutor or something like this to simplify the explanation for the patient? Are you using any tutor or no?
Not currently. I am aware there is some online, but we aren't currently using them at the moment. But that may come, and we do have the AccuRx system has a real big library of how to do certain procedures that we need patients to do at home. And so hopefully, if this then takes off, we will be able to add something to that so the patients can actually view that on their telephone. but it's something, obviously it's only early stages at the moment. So at the moment, they're just relying on protocols for the staff and careful instructions in simpler kind of nice bullet points for the patients.
And Melanie, if I understood, we can download the blood pressure values from the device?
Yeah, we can. At the moment, we use a paper to record the blood pressure readings, but with the Night View, you can actually Bluetooth it to a device, which is usually straightforward, but because we're doing it in general practice, there's a certain amount of security to go through to download it to a patient's record. So we're just navigating those sort of teething troubles at the moment. But yes, it's much more straightforward. The ABPM requires the patient to come back in and we remove the monitor, and then we have to plug it in and start the software, and it's inevitably has its issues, so it's not a quick experience at all.
This is an important point to be highlighted because we are avoiding all the misreporting issues. If you can download it automatically, it's much better. Thank you, Melanie. We still have 5 minutes. Let me, just before doing the conclusion and raise some question. Can you give us any take-home message to improve hypertension control and cardiovascular risk reduction? Matt, let's start with you. Any take-home message to improve hypertension control and cardiovascular risk reduction? Terry, let's.
Well, I would certainly be focusing very much on using our eyes as our best tool. So identify those patients that come in with lots of tummy fat, lots of that dangerous central or visceral adiposity that we know is a risk factor for all other cardiometabolic renal risk factors. They're most likely going to be the ones that have got associated sleep apnea, diabetes, kidney disease. And so we need to be screening them for hypertension per se, but then also the nocturnal hypertension.
So Matt, it's screening and detection. It's very important for you in the type of patient that you mentioned and you highlighted. I will add only one profile of patient as a hypertension specialist. Patient with high normal blood pressure ranges may present nocturnal hypertension, even if in the clinic they are only at high level, 130, 139, 80, 89, 85, 89 millimeters of mercury. These people, in terms of prevalence of nocturnal hypertension, may present also high prevalence of nocturnal hypertension. Take-home message, Terry, from your side?
My take-home message is that this is a new concept in primary care, nocturnal hypertension. This something that Mel mentioned there. We're on a steep learning curve, and a lot of our staff and hypertension management is predominantly done in primary care by our nursing staff, but they just are not aware of the importance of nocturnal hypertension, and so we're having to make them aware of that and emphasising that that this particular device that's what it's mainly about, rather than the daytime measurements.
Thank you, Matt. Melanie, any take-home message to improve hypertension control and cardiovascular risk reduction?
Well, from a nurse's perspective, if the patients are happy, then we're happy, because if they are more likely to use a device because it's comfortable and it doesn't interfere with the sleep, it's easy to use, it's not as keen around the arm as the brachial one, it seems to be quite gentle and unobtrusive, then they're more likely to have a better result and also more likely to be compliant. So if we can get the readings at home, then we're more likely to see a realistic results so we can know who we're treating and why.
Thank you. Thank you. Let me have some question from the participants. There is a number of a question. One of them, it's for all of you. Is there any best time to look for nocturnal hypertension? Is there any specific time or best time to look for nocturnal hypertension? In my opinion, he is asking, shall we look at it at midnight, at 2 a.m., at 4 a.m., or as you mentioned it, Terry, in the morning rise? Is there any specific time, or shall we consider the whole night?
So the answer to that is that there have been various studies, and that's why they've directed it at 2 and 4 o'clock. The problem with ABPM is that it's all night long, and it's every half an hour, and disturbs sleep. But the studies do indicate that 2 and 4 are probably the best predictors. And of course, it depends on your working and living life, your circadian rhythm. One of the things that we haven't mentioned here is that some people are nighttime workers and such like, or people who travel for work and such like, and so they have very disturbed lifestyle because of that as well. And one of the things is there's a lot of unknowns here, and the precise best time we don't know necessarily.
Okay, thank you, Matt. So for the moment, let's consider the full night level, as you mentioned at the beginning, 120/70, and let's see. Another question in this direction, Terry, is, can nocturnal hypertension be an isolated condition? This is very
yes, it can. So there's this concept of masking. Well, not somewhere that I would enthusiastically go in primary care, but so we have masked hypertension per se, where which is the opposite of white coat hypertension, where your blood pressure is low in the clinical home, but also you can have hypertension where you a hidden nocturnal hypertension in someone who appears to be normotensive during the day.
Thank you, Matt. And this is very important. So yes, it can be an isolated condition. It can be a masked nocturnal hypertension. It can be different than deeper, as you mentioned, and non-deeper, as you mentioned it at the beginning. So it's something very important, and we are going to learn more and more about this nocturnal hypertension as an isolated condition. This maybe it's for you, Melanie. The question is, could the night view monitor lead to reactive hypertension, particularly for anxious people who don't sleep well, according to your experience? Do you have the experience of this? Any sleep disturbance in patient who doesn't sleep well?
Yeah, initially when we first started doing the ABPMs, you got quite a few people really weren't happy with the sleep disturbance. So obviously they were getting anxious about it and coming in saying, well, I couldn't cope with this. We haven't done enough with the night view monitor to really find that out as yet, but all the questionnaires that have come back have said that it is literally the ease to wear and the not being woken up and how gentle it is. So really, I'd like to think that the night view monitor is going to be less likely to cause anxiety, but there is always going to be an element of patients that are not happy when they've got a device on their person, and it is going to create anxiety, which will obviously in turn, in most cases, put their blood pressure up. But we would hopefully be able to know the patient and be able to gauge the patient's reaction to the suggestion of having the blood pressure monitor at home. And if they really are averse to it, then obviously we would have to think of a different method.
Okay, thank you. Another question from Germany this time. What is the role of pulse wave velocity as a predictor for nocturnal hypertension? Is there any role of pulse wave velocity? Can you allow me to answer this? Since I am the pulse wave velocity man, I spend my life on arterial rigidity. In my opinion, no, there is no direct relationship between the pulse wave velocity. Pulse wave velocity is reflecting arterial stiffness, arterial rigidity. So maybe in patient with very high atherosclerotic and defective baroreceptors and so on, at the end, we can observe nocturnal blood pressure. But at my knowledge, there is no direct relationship between pulse wave velocity and nocturnal hypertension. Let me try to conclude. We still have 1 minute to conclude. We learned a lot of things tonight. I don't know from your side, but from my side, honestly, I learned a lot of things, and I would like to address you my thanks to the expert, to the speakers for this. What I learned from Terry at the beginning that it's important to be interested by the nocturnal hypertension, because this nocturnal hypertension, it's a kind of a specific condition. It's important to be considered because it's an independent predictor of cardiovascular events, and we have to take it into consideration. And when we consider it, we have different ways to treat it. We can discuss long-acting treatment, combination in the morning, in the evening, according to the patient profile, and so on and so on. What we learned from Melanie was very, very interesting in terms of practical aspects, that we can measure nocturnal blood pressure using two techniques: 24-hour ABPM, which has been used a lot, and this new technique, the night view device. She highlighted for us the limitation of the 24-hour ABPM. It's expensive, not available everywhere, need time consuming to program the device and so on, the reluctance from patients to repeat it. Some patients refuse to do it during the night, and so on and so on. And she highlighted for us also the experience with the night view, that it's acceptable, high acceptability by the patient, comfortable, easy to use, and so on. So there is a potential here. And what we learned also, and it's very, very important for us from Matt, is in what kind of patient, it's the patient phenotype when we have to look to this nocturnal blood pressure. A number of situations, but he focused on the metabolic syndrome, obesity, and metabolic syndrome patient, and he highlighted for us also the high level of blood pressure, with the importance of sleep apnea. I was really impressed by the percentage and the prevalence of sleep apnea, and why it's important, and the comorbidity with the sleep apnea as cause of resistant hypertension and as the association with other cardiovascular condition. So allow me to thank you all to be with us tonight, and to thank specifically Omron Healthcare and Omron Healthcare Europe for their support and for making this webinar possible. Thank you very much.